We're going to talk a little bit about neonatal resuscitation, and we're going to take an update. The only thing that I have to disclose is that I am a director for the American Board of Anesthesia, and as a director for the American Board of Anesthesia, they do pay my department a small stipend to compensate for the time that I give to the American Board of Anesthesiology. We're going to get a chance. We're going to review a little of the update on neonatal resuscitation. We're going to apply these things to the clinical situation. Remember, this is a clinical meeting. To sit there and me just tell you this is not. We're going to know how to apply it when the clinical situation and identify pitfalls in this. And what you see here is, so I just moved to Kentucky. I've been in Kentucky since September 1st. And so I want to be liked and you want to be part of a team. So they said, please join our team. And what this team was the polar plunge. So what is the polar plunge? Yeah, notice they're all young except the one guy there, me. This is where in February, when the temperature was about 40, we jumped into a pool because there is no ocean there, so we jumped into a pool. And just to make sure that it was, well, every half hour they kept dumping ice into the pool. And yes, we did it, and the only reason Karen here is wearing a chicken suit. She said that was her compensation because she wasn't going to jump. And as proof, yes, we did jump, and you can see us afterwards. These are all just real smiles, and it was a lot of fun. So what we're going to do is, this is my typical day on labor and delivery. You know, I love covering labor and delivery. Generally, you know, you do a couple C-sections, watch some labor epidurals help out. But we had a G3P2. She had little prenatal care. You know, she comes in, she's 37 weeks pregnant. Her epidural goes placed at 6 centimeters. She's comfortable. It was the most uncomplicated delivery that you would expect, except afterwards, baby wasn't breathing. And they called a stat overhead, and we had 15 people running into the room, yet my anesthesia team was the only one skilled in airway management. So my nice, perfect day on labor and delivery changed. And I think what we have to look at is malpractice in obstetric anesthesia. So this is old, you can see, 2009, but it's still such important data. And this is the closed claim. So anytime a malpractice claim is filed against an anesthesia provider and is settled, it gets reviewed by 3. And on the review, we're sitting there saying, what can we learn from it? And what we're going to see is they have 2 types. There's claims pre-1990 and post-1990. And the reason they're dividing up into the 1990s is because now we're seeing more interest in obstetric anesthesia, and we're trying to see any trends that are going on. And I think the most important thing you can see, maternal death was very common. So this is, remember, it's not incidence. This, you're only getting the numerator. You have no idea what the denominator is, and it has to result in a lawsuit. If it happens and it doesn't suit, we don't see it. But you can see the majority of cases are from maternal death, we see maternal death, and then newborn brain damage. When you go post-1990, there's been a drop, but the biggest thing is, take a look, you can see that nerve injury, very high, but newborn brain injury still represents a significant cause that a malpractice suit is going to be filed against an anesthesia provider. So the second leading cause of a malpractice claim being filed against an anesthesia provider is for newborn brain injury. And the thing is, if you look at it, majority of them had poor tracing, and the biggest problem was their failure to communicate. There was poor communication between the anesthesia provider as well as the obstetrician. And I think the problem is because we follow a social norm of communication. And you got to like this, and this is why we lift on 3. You know, you can see what you have there is the patient on the floor. I think one of the key things is we're polite. We're not supposed to interrupt, and we're not supposed to raise our voice and disagree. We're very following that. And I think that was one of the nice things when we heard about the drills yesterday, and we listened to Dr. Hess. What I think the key is, if you remember, really I can summarize what Dr. Hess did. He changed the culture. He changed the culture on his labor and delivery, empowering people to speak up and communicate, because we're not very good at communicating under pressure. And for example, we can see here, what we have here is a situation where we're going to look at anesthesia providers as well as obstetricians. And this is what the obstetrician is facing. They know they have this. You have a bad tracing. So I think we would all agree, we'd probably consider that this is urgent. In my place, we would have called this a level 1 cesarean delivery for prolonged fetal bradycardia. But the thing in this case, it is a difficult airway, and the person has chosen to do a spinal. And now they're going to see, how do the anesthesia providers and how do the obstetricians communicate? When you look at the anesthesia provider, we're very, very good at telling what's going on. I'm doing a spinal because I am going to concerned about a difficult airway. I know that I'm concerned. I'm going to do this. So we're very good at that. What we're not very good is asking the obstetricians, what are you doing? Hey, how's it going down there? Are you bleeding? How's the uterine tone? One of the things that we learn from this, one of the most important forms of communication that's important, we have to feel comfortable talking to the obstetrician saying, how's it going? They have no problem. You can see they're very good at advocating information. Oops, sorry, I keep hitting that button. They're very good at advocating. They're also very good at asking us, what's taking us so long? Can we go? How's it doing there? They're very good at that. We're not so good. And one of the take-home messages to help us improve communication, is this a stat C-section? Do you need to go within 30 minutes? Do you need to go now? What's going on here? Why are you concerned? Is there a risk of bleeding? Is there a thing? We have to feel comfortable asking, not only advocate, but also inquire. Because I think that's one of the key things that hopefully you heard from Dr. Hess's lecture yesterday was communication is important. So the only reason I bring this forward is because it gives us a chance, because remember, communication was the leading reason that there was a reason of a lawsuit filed against an anesthesia provider for the neonate. In 2015, there was a change to neonatal resuscitation, and I think one of the key things, this comes from the International Liaison Committee on Resuscitation, and they will do a change every 5 years. So right now we can tell who's ever running the Shnider meeting in 2020 that there will be another new neonatal resuscitation guidelines. And I think one of the things about this, I think how brilliant is that? Every 5 years, they have it on their calendars. Let's take a look at it and see what can we do. I think one of the things that was important when you look at this is one of the things, I think, you know, if you don't think you can get promoted in academics, you're wrong. Tell me if this doesn't make sense. They asked participants, and they gave them a simulated neonatal resuscitation. And they asked them, how long? So at the end they were saying, how long was it before you did this? How long would you do it? Guess what? They all underestimated the time. It was all much longer than they thought. Of course, we know that. We don't have an idea of the passage of time during a resuscitation. Hence the reason it's important for the team leader to say, you, Manny, you're going to do the clock, and you're going to let me know when it's 1 minute. Sit there, designate that, because you're going to be surprised at how fast the time runs away on you. And I think one of the key things, birth of a baby is a good time. Most things are good outcome when we talk about that. And I think the most important thing is what we're going to be there. What is neonatal resuscitation? It's where we're helping that kid transition from the extrauterine to the intrauterine to extrauterine life. There are a lot of changes in that kid. That is the most stressful. They think, you know, kids think the most stressful day is the SATs. They think it's the most stressful day is the, you know, college acceptances. Hey, it ain't nothing than what happened to them when they were born. And all of a sudden, their lungs, which weren't doing anything, now have to supply the oxygen. And all these various circulatory changes that do. And to give you an idea, only about 1% of neonates born require some form of resuscitation. So, as we already said, before birth, almost all the oxygen comes to the uterine blood flow. Uterine blood flow at term is 500 to 700 cc's per minute, hence the reason all these discussions about hemorrhage. And I think one of the key things, very little blood passes through the lungs. You know, it's going to go through the foramen ovale here, and then you have a ductus arteriosus, which causes it to bypass the lungs. There's very little blood flow, but then after birth, the majority of blood flow, all the blood has to go through. So that foramen ovale has to close, and the ductus arteriosus has to close. And all this is felt to be due to this increase in systemic vascular resistance with the clamping of the umbilical cord. And I think one of the most important things to realize, too, is that we're talking about breathing. And when we look at apnea, there's two types of apnea. There's primary apnea and secondary apnea. The most important thing to realize is that primary apnea responds to stimulation. You know, the come on baby, rubbing the back, flicking the feet, you know, minor stimulation. You don't smack the kid anymore, though, you know, that's from the 1960s. But just gently rubbing the back, that apnea responds. The problem is secondary apnea does not. Secondary apnea only responds to positive pressure ventilation. Well, you sit there and say, well, of course, then that means if the kid you rub and that stuff, to realize is that primary apnea can occur in utero. So when you see an apnea at delivery, you can't tell if it's primary or secondary. So if the kid doesn't respond to the stimulus, start positive pressure ventilation. one of the recurring themes is this delay in initiation and positive pressure ventilation. If that kid doesn't respond to stimulus, assume it's secondary apnea and start to ventilate. And I think that's the key. That's what we're talking about here. Here's your primary apnea, secondary apnea, primary apnea, secondary apnea. Primary apnea does not respond to primary apnea responds to stimulus, secondary apnea does not. If they don't respond, you have to assume secondary apnea. I think one of the key things at a resuscitation should not be a surprise. You know it, you see it, and these are various things that can cause that. Who should do the resuscitation? It's very clear in the guidelines that get published. So remember, it is a guideline, but the anesthesia provider is not responsible. I think the important thing is you have to be careful. Several of my residents have come back because they have been asked to take jobs where they are listed as the primary provider for the neonatal resuscitation. I tell them, you know, obviously if you love the job, but be careful about that. You are now responsible because it's in the hospital policy. And that means that if the mothers have, you are still responsible for the neonate. And I think the key, as you can see in the 2015 guidelines, is they say every birth should be attended by one person who can do the initial steps. And I think one of the key is, notice what they say here, whose only responsibility is care of the newborn. Whose only responsibility is care of the newborn. So since your job is the mom, that cannot be your job. You will be asked to help. You will be asked to help, but it cannot be your job. When you look at delivery, I think there's a major change. Now there's this delay in umbilical cord clamping. So infants not predicted to require resuscitation. So where you're sitting there and the kid looks good, they're saying wait about 30 seconds, a little bit. What you're trying to do is give the kid a little more blood. And what's interesting, this delay in umbilical cord clamping has a lower incidence of intraventricular hemorrhage. They have higher blood pressure, higher blood volume, less need for transfusion. So unlike before where it was get the kid out, clamp, do it. Now you're going to see, get the kid out, delay a little bit, get that 30 seconds, and then clamp the cord. And again, remember that passage of time. It's really interesting. They think they wait 30 seconds, but you know, it's that it's very clear or very hard to keep track of time. I think one of the other things, keep the kids warm. Labor rooms, or delivery rooms should be warm. They're not meant to be cold. Labor rooms are easy. They're generally warm. C-section rooms are supposed to be warm. You're supposed to be working in a hot environment. It should feel like a trauma room. If it doesn't feel like a trauma room, it's not warm enough. Because we definitely know that hypothermia in the neonate is associated with poor outcome. Temperature should be between 36.5 and 37.5. Hypothermia increases the risk of intraventricular hemorrhage, respiratory hypoglycemia, and late onset sepsis. So here's an easy one. If your C-section room is cold, warm it up. Right? That's as easy as it comes. Warm it up. It's supposed to be warm because we do know that any hypothermia in the neonate is poorly tolerated, especially in low birth weight. And in low birth weight now, they're recommending covering the kid in plastic and placing infant on a thermal mattress. And you can see, well, this is not an actual baby, but here they cover the kid in plastic. Term infants become cold too. I think that's the most important thing. We think preterm, but poor. And if they do get hypothermic, there's poor feeding, respiratory distress. And so one of the key things, you can see the WHO guideline states that your temperature in your room should be 78. Think about it. If you're not sweating, and if the obstetricians are definitely not sweating, your room is probably cold enough, not cold enough. Warm up that room. One of the most important things you can take away from this is that. The other thing you can do is this skin to skin. I'm not going to touch on it because my colleague is doing this, but you can see this is mom doing skin to skin, and here's dad doing skin to skin. So this always freaks me out. So I never forget the first time I walked into the OR without a mask on, or I forget, maybe my hat. I had a little hair. This one I had hair, but I had a little hair sticking out, and the scrub nurse, your hair's out, and I had to go back and put it in. I'm like, okay, I got there. Now in the back, there's dad taking his shirt off, all the chest hair's out. I'm like, okay, I'm old. And the thing is, even in Kentucky, they do skin to skin. I think one of the key things to realize is that, meconium happens. I think the key is meconium happens. Anybody who does obstetric anesthesia knows that meconium happens. What are we talking about? Meconium is that stress, it's that stool that occurs in utero. And the thing we're concerned about is if they should aspirate meconium, do they develop an meconium aspiration syndrome, which is much like ARDS. And what we can see here when we look and go back, I can remember assisting our pediatric colleagues with the resuscitation and intubating the kids, right? We've all been there. Then it went to, well, you didn't have to intubate vigorous, but if they weren't vigorous, then you should intubate. And now in 2015, Tracheal intubation is not indicated for meconium, even if the kid is not vigorous, even if the meconium is thick. No longer. You are harming more kids, not you, I mean they were harming more kids with these intubations than doing anything. So tracheal intubation has gone, even resuscitation of thick meconium, positive pressure ventilation. Big emphasis on pulse oximeter. If you're not using a pulse oximeter, you should. And one of the things is to make sure that you have a pulse oximeter on the kid. They've really changed a lot of guiding questions. You really should be asking, is this a term gestation? How's the tone, and is the kid breathing? That's going to help you. So things that have stayed the same, put the kid on a warmer. We know the kid is cold, and then you give the stimulus and see. I think after that, you stimulate, we said, and then suction the mouth first, and then the nose. Evaluate, remember, it's respirations and heart rate. Color, you don't evaluate color because it's not very helpful. When we look at heart rate, I think the change has been, boy, don't you remember, and when you first were doing your neonatal resuscitation being trained, you're supposed to feel the brachial pulse because you're not going to be able to feel the carotid pulse in a neonate. And then we switched and we said, all right, let's put our fingers on the umbilical cord, and we're going to feel the umbilical cord pulsations. Problem was, it was so inaccurate. So they said, well, really what you should be doing is listening, right? We should be listening, and that's failed. Now it's changed. They feel that EKG is the most reliable way. And when you look at this, it's very easy and very quick to put an EKG on the baby and get a heart rate that's very accurate. When you ask 64 very experienced practitioners in pediatrics and neonates to assess the heart rate, and they asked them, what is the heart rate? And they had an EKG on, and they had the people, it's really horrible. They're very poor. When that heart rate's going that fast, and your heart rate's going just as fast, it's not very good. So put an EKG on, and you can get that. You can see 50% of the time they were wrong, leading to errors in the resuscitation. When we look at this, the guidelines coming down very strongly. Put an EKG on. The amount of time it takes to put an EKG, 20 seconds. It's even faster than a pulse ox. 3 leads, you have your EKG, and you get a very accurate assessment of heart rate. Unlike auscultation, unlike palpation. Palpation's the worst. EKG, auscultation second with a stethoscope, and then the best way is by EKG. Ventilating, it's still, this hasn't changed. Ventilate about a rate of 30 to 40, and with initial pressure of 30 to 40, you breathe at a rate of 40 to 60 with initial pressure of 30 to 40, and then subsequent breaths are 15 to 20. After ventilation, you assess the person to assess the heart rate, and if the heart rate's not improving, adjust your ventilation. Almost all reasons there's bradycardia is because of inadequate ventilation. So it's ventilate first, and if there's no response, recheck your ventilation because that's going to help. What do you ventilate the kid with? Major change. And now the recommendation is you start with room air. So you start with room air before going to oxygen. And it comes from this study. So it's old. You can see, sorry, I keep doing that. It comes from 1998. And what they did is a multi-institutional study. They took apneic infants with a heart rate less than 80. So there's no question, these kids needed resuscitation. And they either resuscitate them with room air or oxygen. What did they find? Is that when you compare it, that of the infants, 288 got ventilated with room air, 321 got ventilated with oxygen. Median ages was 38, and you can see these kids needed it, but the most important thing, there was no difference. No difference. Maybe the biggest difference they see here when they look at this, so when we're talking about this, there's no difference on ischemic encephalopathy. The APGAR score was higher in the room air group. Wow, who would have guessed that? And when you look at this, they cried sooner and they initiated ventilation sooner. Statistically significant, probably clinically insignificant, but I think the take-home message is we learn this is relatively easy. This is very beneficial to our low resource areas, our countries that have low resources. You don't need oxygen in the delivery room, you just need an ambu bag and ventilate the kid with room air, and you can see there's a pretty significant response. I think one of the most important things, there's been some concern with oxygen, and where did this come from? So it comes from the fact that we know that in ischemic situations that you can generate these oxygen-free radicals. And oxygen-free radicals have been described to cause the retinopathy of prematurity. All those problems that we see with in these term kids is felt to be due to these oxygen-free radicals. Why is that important? Well, we know if you ventilate with oxygen and expose them in ischemic tissue, you can get these free radicals. So you're sitting there saying, so what? I thought the cool thing is, take a look at this picture. So what you see here, this is your non-asphyxiated neonates, so non-asphyxiated neonates. These were asphyxiated neonates. So what you see in the dark, these were the ones who were resuscitated with oxygen, and you can see at 28 days afterwards, you're still seeing a difference. There's still evidence of this oxygen-free radicals 28 days later that you didn't see in the room air group. Now, again, I've proven this, we've seen this, I don't know the clinical significance of it. So you're saying, so Bob, what's the clinical? I don't know. I think one of the key things is that the room air tends to go back, so we see that. But we don't know, is there? We have to keep looking, and they are. But I think the most important take-home message is room air works just as well. And when you look at them 2 years later, no difference. And so here's a meta-analysis, 1,500 patients, 772 in the oxygen group, no difference in death, no difference in ischemic encephalopathy. So the take-home message, start with room air. And then if the kid doesn't respond, because now we're putting pulse oxes on, that's when you start using oxygen. Chest compressions, no difference in the number. You know, if the heart rate's less than 60, you would do chest compressions. The biggest change is the two-thumb technique is the preferred. Remember, we used to go teaching that you should be doing the two-finger, and a lot of people felt more comfortable with the two-finger. Now they've shown that with the thumb, you're able to generate better intrathoracic pressure. So the recommended chest compression method of the neonate is now the two-thumb technique with your hands encirculating the thorax. Generates higher pressure and higher coronary perfusion pressure. And basically, it's you do one ventilation, 3 compressions, 1 ventilation. So at the end, you should have 30 breaths and 90 compressions per minute. And it's going fast. I think that's the thing about this, to keep this up. And hence the reason you want to make sure you have people skilled at that, because it's 30 breaths with 90 compressions in 1 minute. So you're doing 1 breath with 3 things every 2 seconds. Medications, 30 seconds of well-coordinated CPR, you check the pulse, and if the heart rate is still less than 60, you would initiate medication. If the heart rate's greater than 60, you stop the chest compression and see. What are the medications? They really now are saying even in the neonate, if you don't feel comfortable, it's okay to do the intraosseous. I have now, for my first time, in a trauma victim, placed an intraosseous line. And that was part of one of the trainings that we had. And this occurred at my new institution, so I would feel comfortable. I don't know, I do know. I would not feel comfortable doing this in the neonate. I still probably would try to think of something else. But you can use the intraosseous route, and you can see here the average time to place it. They're much faster in obtaining the intraosseous than intravenous in neonates. Epinephrine is the first drug of choice, used 1 to 10,000, and it's 0.01 to 0.03 milligrams per kilograms. If you're going to give it endotracheally, you need to give it in a higher volume, and it might be a higher amount, 0.1 milligram per kilo in that case. Volume, if the kid is pale, you can give them saline, Ringer's lactate, or O-negative blood. Bicarb is only indicated to correct a metabolic acidosis. In reality, you should not give it unless the lungs are adequately ventilated. And the concern is that it leads to the central pontine myelinosis, so it needs to be given extremely slowly. So I think most people would say there really is no role for bicarb. Naloxone, 2010, it was recommended as part of the primary resuscitation. I'm happy to report in 2015 it was removed. Because the problem was that pediatricians were going too quick to naloxone. They said, oh, if the baby's not breathing, it has to be the opioid that you gave the mom 4 hours ago. And what they were doing is, remember, what's the first step? You got to assume it's secondary apnea. And it isn't, secondary apnea is not treated with Narcan. It's treated with positive pressure ventilation. And that was the problem with it. So they said Narcan is no longer a first-line drug. Narcan is a second line. After there's been no response to positive pressure ventilation, no response to the chest compression, then you consider naloxone. But the first step is always positive pressure ventilation. And as you can see, we have a long way to go. We can see here's naloxone dropped. So the good news is it has dropped, but you can see naloxone 42% are still using it without ventilation. And you gotta love it. 1 out of 10, mom never even got an opioid. Mom never got an opioid, and yet they're still giving naloxone. And hence the reason you can see, this is one of my favorite. Anybody not see this picture before? What do you see here? Is that an old woman, right? Old woman with a nose, mouth, or is this a young woman with her head turned and there's her nose? And you can't tell, and that's what we're seeing here with the naloxone. Yeah, we've gone a long way, it has dropped, but we're still using it inappropriately. Intubation, the amount of time it takes you to read this slide is the time period you should intubate. Blade size 0, 1. I think one of the key things, there's been a really major resurgence in the use of the LMA, and that's actually what we have available in our LDRs in Kentucky. And the reason is because everybody felt comfortable putting in the LMA. And by that time, because we do have pediatricians in-house covering the NICU and the PICU, by the time they're downstairs, we will have bought enough time. And the reason we chose that was because we noticed that every nurse with some SIM training felt very comfortable putting an LMA in. None of them felt comfortable with intubation. All of them felt reasonably comfortable with LMA, and it's the same thing, I would argue, probably with our anesthesia residents, also with our CRNAs, as well as our attendings. It's easy, it works, no difference in success of ventilation. We've really have replaced, so we do have the endotracheal tubes, but now the fact that we don't intubate for meconium, we have chosen that the LMA is our primary until the pediatricians come down and help us. I think one of the key things, it's okay to not start resuscitation. They said providers should not hesitate to withdraw support when functional survival is unlikely. And this is, when you look at the gestational age and with uncertain prognosis. And this raises the question, what is the definition of fetal viability, right? The current definition is 24 weeks, right? 24 weeks is fetal viable. Anything before 24 weeks is considered periviable or pre-viable. And this has implications about when you can do D&Cs for this. And here's an example. Here's rethinking viability. So here's a 22 and some day fetus. Look at this, 22 some day fetus. Look at the kid now, okay? 22 and some day, pre-viable. Yet in an appropriate NICU with the appropriate staffing, they're having reasonable success. The problem with this is when you see a story like this, everybody thinks the Betty White story. Everybody looks at Betty White, and that's how they think they're going to be when they're 95, still doing TV shows. What they don't see is all the patients we see in the OR who are 95 and not doing well. And I think the key to this is the same thing with appropriate sources, but it raises the question, what is viable? And that's what ACOG is kind of respond. Taking a look at this, babies born between 22 and 25 weeks. You can see 23 weeks, death or neurodevelopment. You see high. Look at 24 weeks and 25 weeks, it goes down. But it's not 100%. For infants, 23 weeks, lower incidence of death if you give steroids, 22 weeks. And so I think the key is, as long as you're willing to do a C-section, that's the only thing that's been shown. Steroids, as well as magnesium for cerebral protection, as well as doing a C-section seems to be help. And this is what you can see with ACOG. Take a look as you go down. We're really starting to see there is some survival in this time period. So this is the 22, really early, but we're starting to see survival in these 23 weeks. We're really being challenged. Remember, the definition was 24 weeks. Before 24 weeks, you didn't do a resuscitation. Now, in some institutions, 23 weeks, they're having pretty good success. And I continue that I argue we're going to keep pushing the envelope. And my guess is in the next 2020, they're going to say a much younger age, because in this one, they use 24 weeks. When should you stop a resuscitation? The APCAR is 0. At 10 minutes, stop the resuscitation. I think that's one of the key things. Unlike where you watch resuscitation of adults, where the CPR goes 30, 40 minutes. We've all been in those situations. I really respect this. They say, listen, if the APGAR is 0 at 10, stop. And because there's no chance of any good outcome in terms of brain function as well as neonate afterwards. Post-resuscitation afterwards, the big thing is this cooling has been shown to be beneficial. And what they're doing now is this cerebral cooling, putting them in a cooling cap so you don't have to cool the whole body. And that seems to be very helpful in terms of preventing disability. How do you improve a resuscitation? Teamwork. Got to work together. I think one of the key things we've learned already is in communication with our obstetricians and then communication amongst the team. But practicing it, doing it, and I think as we saw, pretty impressive pretty impressive success with these young-term neonates. So in summary, if you are the provider for the mother, I think one of the key things, you are not responsible for resuscitating the newborn. That doesn't mean you help. You don't help. I mean, you're going to have to help. And they'll ask you, but remember your primary responsibility. They should ask you. You should not be working a place where it's your job. And if it is, start time to renegotiate the contract, because your responsibility is to the mother. You are there to help the newborn if it. Assess breathing and heart rate. Remember, there could be secondary apnea. Usually they respond to positive pressure ventilation. Don't be scared of the LMA. I encourage you, if you don't have LMAs, make sure they're there, because the one thing on a sim, you can get your labor and delivery nurses very comfortable very quickly with LMAs, and I've been very impressed with it. And it's okay to not initiate with a poor prognosis. With that, I'm going to turn it over to Alex, who's going to introduce our next speaker, and I'll be able to take questions when we get a chance to meet for the panel. Thank you very much, and thanks for getting up so early. I appreciate it.